The paranasal sinuses, maxillary air sinus. Hi there! In our previous videos, we covered the anatomy of the frontal ethmoidal and the sphenoidal air sinuses.
Next up, we have the maxillary sinus. This sinus, also known as the antrum of Highmore, is the largest of the paranasal air sinuses and is located within the body of the maxilla or cheekbone. Developmentally, the maxillary sinus is the first to appear around the fourth month of intrauterine life as an outpouching from the mucous membrane lining the lateral wall of the nasal cavity. At birth, it is rudimentary but undergoes rapid enlargement during the ages of 6 to 7, becoming fully developed at puberty after the eruption of permanent teeth. The maxillary sinus has specific measurements with a vertical dimension of 3.5 cm, a transverse dimension of 2.5 cm, and an antero-posterior dimension of 2 cm. It has a pyramidal shape with the base directed medially towards the lateral wall of the nose and the apex laterally towards the zygomatic bone. In terms of its relations, the roof of the maxillary sinus is formed by the floor of the orbit, with the infraorbital nerve and artery passing through a bony canal within the roof. The floor, although very small, is formed by the alveolar process of the maxilla and lies approximately 1.25 cm below the floor of the nasal cavity, corresponding to the level of the alae of the nose. Normally, the roots of the first and second molar teeth project into the floor, creating elevations. The base of the maxillary sinus, which is formed by the lateral wall of the nose, contains the opening or ostium of the sinus in its upper part, near the roof. Unfortunately, this position is disadvantageous for natural drainage. The anterior wall of the maxillary sinus is formed by the anterior surface of the body of the maxilla and is related to the infraorbital plexus of nerves. Within this wall, the anterior superior alveolar vessels and nerve runs in a curved bony canal. The posterior wall is formed by the infratemporal surface of the maxilla, separating the sinus from the infratemporal and pterygopalatine fossae. This wall is pierced by the posterior superior alveolar nerves and vessels. The opening of the maxillary sinus is located in the hiatus semilunaris of the middle meatus, near the roof of the sinus. Arterial supply to the maxillary sinus is provided by the anterior, middle, and posterior superior alveolar arteries, which arise from the maxillary and infraorbital arteries. Lymphatic drainage is into the submandibular lymph nodes, while the nerve supply is derived from the anterior, middle, and posterior superior alveolar nerves and branches of the maxillary and infraorbital nerves.
Clinical anatomy of maxillary sinus. Maxillary sinusitis, an infection of the maxillary sinus, is the most common among all sinus infections. It can occur due to various reasons, including the spread of infection from the nose in case of viral rhinitis or infected frontal and anterior ethmoidal sinuses. If the sinusitis is a secondary infection caused by dental procedures or the spread of infections from carious upper premolar and molar teeth, it can be called odontogenic maxillary sinusitis or OMS.
The maxillary sinus acts as a secondary reservoir for pus from the frontal air sinus, as it is the most dependent part, with pus draining through the frontonasal duct and hiatus semilunaris. The pain associated with maxillary sinusitis is often referred to the upper teeth and infraorbital skin due to the shared innervation by the maxillary nerve. To address maxillary sinus infections, there are two common surgical drainage approaches. Antral puncture, also known as antrostomy, involves using a trocar and cannula inserted below the inferior nasal concha in an outward and backward direction. Another surgical method is fenestrating the antrum through the canine fossa in the gingivolabial sulcus, known as the Caldwell-Luke operation. In cases of carcinoma of the maxillary sinus, which arises from the mucus lining, there are specific signs and symptoms associated with the invasion of the carcinoma into surrounding structures. For example, upward invasion into the orbit can displace the eyeball, leading to proptosis or protrusion of the eyeball, and diplopia or double vision. Involvement of the infraorbital nerve can cause pain and anesthesia in the skin over the face below the orbit. Downward invasion into the floor may result in a visible bulge or ulceration of the palatal roof of the oral cavity. Medial invasion encroaches upon the nasal cavity, causing obstruction and epistaxis or nosebleeds. Lateral invasion produces facial swelling and a palpable mass in the gingivolabial fold. Posterior invasion may affect the palatine nerves, leading to severe referred pain in the upper teeth. Pop quiz.
Although first discovered and illustrated by Leonardo da Vinci, it was documented by the anatomist Nathaniel Highmore. When a maxillary tooth is lost, the implant has to be inserted upward. This means the bone should be able to provide better support. However, due to the thinning of the alveolar bone, the implant may not be stable. It is like hammering a nail into a roof that is too thin. To tackle this, a sinus lift procedure is used to augment the bone and enhance the ability of the bone to support the dental implant. The lateral window technique and crestal approach are the two most commonly adopted techniques. Complications involve rupturing the sinus membrane, bleeding, and chronic sinusitis. Other serious but rare complications are failure of the implant, oroantral fistula, and nerve damage. This brings us to the end of this video. We hope you had fun learning with us.